Okay, let's go ahead and get started. Welcome to the NANETS monthly virtual programming session, Wheels of Awareness, Navigating Neuroendocrine Tumors for APPs and Allied Health Professionals. This webinar is jointly provided by the Advanced Practitioner Society for Hematology and Oncology and NANETS. My name is Rachel Eyring. I'm an assistant professor of oncology and supervise the medical oncology NPPA group at Mayo Clinic. It's my pleasure to moderate and speak at today's educational webinar. Our featured speakers will give a presentation and then we'll be able to engage in a question and answer discussion. This activity has been planned and implemented in accordance with accreditation requirements and policies of the Accreditation Council for Continuing Medical Education and the American Nurses Credentialing Centers Commission on Accreditation. Earn AMA Category 1 credit and nursing credits. A link to attain credits was provided by email to all registered attendees today and will also be provided post-webinar. NANETS is committed to increasing diversity within our activities and structure to reflect all aspects of the neuroendocrine community we serve. We strive to cultivate an open, transparent, and supportive culture where all are welcome. We encourage members to contribute and participate fully. For more information, please visit nanets.net. Now it is my pleasure to introduce our speakers and case presenter for today. Our first speaker, we have Katie Barnett. She's an adult gerontology acute care nurse practitioner, an instructor of molecular imaging and therapy at Oregon Health and Science University. Our second speaker, we have Stephanie Moore, senior clinical dietitian outpatient at University of Texas MD Anderson Cancer Center. And lastly, we have Tiffany Vallone, certified physician assistant in the Department of Gastroenterology, Oncology, and GI Advanced Practice Professionals Manager at Moffitt Cancer Center. Following these presentations, we will have a Q&A session. Please place your questions in the Q&A box for our moderated discussion. With that said, we'll get started. And we've got Katie up first.
I'm having trouble getting my slides to move forward. Oh, there we go. All right, so my name is Katie. I am a nurse practitioner at OHSU, and I will be going through a couple of cases with you to discuss practical management tips for symptomatic neuroendocrine patients. These patients are both going to be PRRT patients or peptide receptor radionuclide therapies like your lutetium dotates. So just keep that in mind. I don't have any disclosures. And for our learning objectives, at the conclusion of my lectures, you'll be able to describe and manage common side effects of PRRT. We're going to review some common signs and symptoms of carcinoid syndrome, talk about the use of somatostatin analogs during PRRT, identify acute decompensation following PRRT infusions, and we're going to talk about the importance of optimization prior to starting PRRT. So our first case is an 80-year-old patient with a history of low intermediate grade, well-differentiated neuroendocrine tumor of the terminal ileum with mesenteric nodal mass and liver metastases. He's status post resection of the small bowel, liver embolization, and octreotide therapy. Prior to him getting cycle 1 of lutetium dotatate, he had to hold his octreotide for about 30 days. So when he presented to us, he was reporting worsening diarrhea and some urticaria. I got a call from him 5 days after he got cycle 1, and his patient's wife was reporting significant nausea, abdominal pain and fullness, poor PO intake, weight loss, lethargy, and some mild flushing. So I ordered a repeat CMP and some Zofran for him. And we had a brief discussion about supplemental drinks like Ensure, Glucerna, encouraging sips of water throughout the day to try to maintain hydration and when to go to the ER. The surgical oncology team, who was managing his octreotide prior, also ordered some tramadol for him and some short-acting octreotide. The repeat CMP that I got back a couple of days later showed that he did have some transaminitis and mild hyponatremia, and the short-acting octreotide had not resolved any of his symptoms. So he was referred to the local ER, and he was admitted for 5 days for acute metabolic encephalopathy and hypovolemic hyponatremia. The case was discussed at Tumor Board. There was a question from the hospitalist where he was admitted regarding could the PRRT cause hyponatremia, and it's very, very rare. And given that he was having this very poor PO intake and some nausea and vomiting, it was probably more attributed to the PO issues. So we decided to get a dietitian consult. So he presents for cycle 2. He's reporting similar symptoms to last time, but he's eating a bit more. Unfortunately, because of the holidays, he was unable to see the dietitian prior to cycle 2. 7 days after he got cycle 2, I got another call from the patient's wife reporting the same fatigue, weakness, poor PO intake. This was on a Friday night, so I advised, let's try to increase the fluid intake up to 64 ounces and make sure that he goes to the ER as soon as possible if his symptoms are worsening or he can't get that much fluid down. So 3 days later, they go back to the ER, and he's admitted for altered mental status, fatigue, weakness, respiratory failure, acute metabolic encephalopathy again, and even suspected meningeal encephalitis. And then he was discharged, and then 3 days later, he was again admitted for 5 more days for basically physical deconditioning. We discussed him again at the Neuroendocrine Tumor Board, and Surgical Oncology decided to admit him for TPN prior to starting cycle 3. He was admitted for 13 days prior to cycle, so for the TPN, and then he did subsequently receive cycle 3, and I haven't gotten a single triage call from his wife. So I'm very happy that the TPN worked for this patient. So what are some common side effects of PRRT? So our most common ones that we see are nausea, vomiting, abdominal pain, bone marrow suppression, fatigue, and diarrhea. Some patients can also get an increase of their serum glucose or serum potassium. I have had one patient that did lose their hair, and cough is another common side effect. And some of the side effects of PRRT can also look like carcinoid syndrome, or they can exacerbate a current carcinoid syndrome. So the most common symptoms of carcinoid syndromes that we see in our lutetium patients are cutaneous flushing and diarrhea, but you can get a whole host of other complications, especially these cardiac complications can be really devastating for patients. So in discussion of case 1, it's important to note that pre-existing carcinoid symptoms increase a patient's risk of having carcinoid crisis during or after PRRT. So this patient would be ideal for optimizing their carcinoid symptoms before they start PRRT. If a patient has to hold the somatostatin analogs, maybe switch them over to a short-acting one, even if it's 3 times a day injections, it still beats having to deal with the diarrhea and flushing that so many patients are complaining of. You can also add telorostat ethyl to the somatostatin analogs. That is for refractory diarrhea, so that can help as well. Interferon alpha, I don't see prescribed very often for our patients. We usually let medical oncology handle that. And it also comes with a host of other side effects like flu-like symptoms, body aches, and things like that that can be really miserable for patients. As a big gold standard, I highly recommend antiemetics and antidiarrheals for these patients, and a registered dietitian consult is always recommended as well. So somatostatin analogs can be used during PRRT with a few caveats. It has to be stopped before they get their Lutathera. So that either needs to be 28 days for the long-acting octreotide or 24 hours for the short-acting octreotide. Usually the octreotide for an anti-neoplastic effect is stopped after they progressed on therapy, but some patients will have these refractory carcinoid symptoms, and that's why you want to continue the octreotide. So then you can restart the octreotide, the long-acting, 4 to 24 hours post-PRRT infusions. So once a patient gets going on their PRRT, they can continue to get their injections throughout and have better symptom management that way. Case number 2 is a 76-year-old female with a history of stage 4, which progressed to stage 5 CKD. bilateral nephrolithiasis, type 2 diabetes, metastatic neuroendocrine tumor, status post small bowel resection in 2001. And since 2001, she had been on octreotide LAR. However, she stopped the octreotide in September in preparation for PRRT, which was delayed because she needed to get treated for her kidney stones before she could actually start PRRT in the hopes that her creatinine clearance would be better. So prior to her starting cycle 1, she was admitted for an AKI following complications of her nephrolithiasis treatment. And her pretreatment creatinine clearance was 11 with a GFR of 7. She was not on hemodialysis. So prior to cycle 1, we discussed her case at length with surgical oncology and nephrology and several times during neuroendocrine tumor board. And after a lot of discussion, we agreed to proceed with a reduced dose of Lutathera followed by dosimetry scans. And the dosimetry scans would give us an idea of how quickly she's able to clear the drug and what kind of toxicity that, or what kind of dose the organs are getting that could result in toxicity. After she got her PRRT and even before, she was reporting significant nausea and diarrhea since she had stopped her octreotide completely for 6 months. We had discussed with surgical oncology and they recommended restarting a short-acting octreotide to kind of control her symptoms, but unfortunately, there was a lot of issue with getting a hold of the patient, coordinating this care, getting prior authorizations and things like that. So she wasn't able to start the short-acting octreotide before she started PRRT. To try to control her symptoms, we did prescribe some Zofran for her and we recommended an over-the-counter antidiarrheal. She came back for her 48-hour dosimetry scan. So she was in our nuclear medicine clinic, reporting vomiting and diarrhea, very poor PO intake, lethargy, and oliguria. This was very concerning because she's staying in a hotel room alone during her radiation isolation. So we wanted to make sure that she got taken care of before she goes back to the hotel. So we started some IV fluids. I sent an order in for the IV compazine, which did help her nausea. We got a point of care glucose, stat CMP, and the CMP revealed that she had increased BUN creatinine and an AKI. So we discussed with the nephrologist who agreed that she should probably be admitted to start dialysis. She was sent to the ER for evaluation and nephrology consultation, and she felt better after getting several bags of IV fluids and declined admission. She was thankfully able to restart both her long-acting and short-acting octreotide after she was discharged, and she seems to be doing okay. Her creatinine is also stable. So in regards to this case, it's important to note that excess PRRT that doesn't attach to a somatostatin target is excreted primarily through the kidneys. So patients with a creatinine clearance less than 20, or really with more recent literature less than 30, are going to be at an increased risk for treatment toxicities since all of this excess drug is circulating for a longer period of time. In addition to the lutetium itself, we also administer a nephroprotective amino acid infusion, which can also cause some nausea and vomiting. So we try to pre-treat our patients, but they can still get a little bit of nausea and vomiting just from that. So for patients who have a history of high emetic risk, so if they have pre-existing nausea and vomiting from their carcinoid syndrome, if they have a low creatinine clearance, if they have a history of nausea and vomiting with chemotherapies, you would probably want to consider prescribing additional antiemetics for several days following treatment. So my antiemetic recommendations are ondansetron, 48 milligrams. I strongly prefer the ODT because I don't want a patient to be swallowing a pill and then immediately throw it up. I usually prescribe this every 8 hours, at least for the 3 days following PRRT around the clock, and then PRN after that. And then for some patients, I also add compazine to that, 10 milligrams every 6 hours as needed. Or, for patients who don't respond well to the Zofran, maybe we'll just do the compazine. Or for patients who have significant constipation from the Zofran, might also do compazine instead. But for the most part, patients tolerate Zofran extremely well. Also important to note with the glucocorticoids. So with a lot of anti-neoplastic therapies, pretty much every patient has been on steroids for some reason or another. It's extremely common for, when I worked in infusion, all of our patients getting chemotherapy also got dexamethasone. However, with glucocorticoids, we want to be really careful with the PRRT, since glucocorticoids, according to some studies, can downregulate somatostatin receptors, which can decrease the effectiveness of PRRT if they're administered together. So in regards to treating nausea and vomiting for PRRT patients specifically, you want to avoid glucocorticoids. There's a small caveat to this, and that patients with a history of a small bowel obstruction related to their neuroendocrine disease, medical oncology sometimes prescribes a dex pulse for like BID for 10 days following PRRT, and that's to prevent a small bowel obstruction. And that's it. Are there any questions? Or I guess we can wait till the end. Okay.
Thank you for that, Katie. That was fantastic. We will now turn it over to Stephanie, who's going to talk to us about nutritional considerations.
Thank you, Rachel. So again, I'll be talking about nutritional considerations for our neuroendocrine tumor patients. I have nothing to disclose. And these are objectives for the presentation or my portion today. Ultimately, I hope you walk away with just an improved awareness of the common nutrition things that we do experience with our neuroendocrine tumor patients, primarily with altered GI anatomies and those with functional syndromes. So unfortunately, a lot of our neuroendocrine tumor patients, because of tumor location, do have a hard time getting in adequate amounts of nutrition and the right types of nutrition. Sometimes this is because the tumor itself or even because of treatments. This, of course, does put them at increased risk for malnutrition. And we know that a less nourished patient doesn't tolerate treatment as well or can have difficulties tolerating treatment. And this often has them seeing us in clinic more often, in the hospital, and just ultimately not doing the things they want to do and affecting their quality of life. So when my patients come to clinic, this is the first question. I get this probably like 10 times a day. What should I be eating? And then my question is, what are we dealing with? Is this a functional tumor, a non-functional tumor? Has there been any surgical involvement? Because all of these factors do play a role in what the patients may be able to digest or how well their absorption is actually is working. So these are the factors that I always tell them, let's get a few bases down first before we start recommending. So just speaking about our non-functional tumors, Katie just went over several things they can experience just because the tumor burden itself, there can be pain, there can be bloating or nausea, and all around eating is just not fun. So for our non-functional tumors that are not having any symptoms or side effects, I encourage them to eat the same thing I encourage all of us to eat, which is a healthy plant-based diet. And I think the diet that most of us relate this to the closest or the most familiar is the Mediterranean diet. And ultimately, it's going to be a diet where 2/3 of the plate is coming from a plant-based source and 1/3 is coming from an animal protein source if you choose, but a lean animal protein source, preferably chicken or turkey or fish over our red meats. Also, I encourage people to reduce their intakes of added sugars just because there's so many of products in our diet that sugar is already added to. So we want to be particular about the things we are choosing and choosing the ones that have the lowest amounts of added sugar as possible. Also, I encourage people to try to limit or reduce your amount of processed foods. Again, because this is not giving us much nutritional benefit, it just tastes good. But we want to make healthy choices all around and save those things for special occasions. So for our non-functional tumors that are having symptoms, the goal is going to be getting in the most amount of calories and nutrition in smaller forms so that we can reduce the discomfort that they often can have just with eating alone. And so these smaller forms of nutrition should be done more frequently throughout the day. I usually recommend every 2 to 3 hours if possible, just trying to graze and nibble on a little bit of something. Often I'll encourage people to alternate their liquids and solids, and sometimes people can get a little bit squeamish about a liquid diet, where essentially it's just maximizing our intake with a lot of nutritionally dense liquids. And these liquids can be things like protein shakes, homemade smoothies, high calorie soups, or even like a Greek yogurt, because these are very nutritionally dense, but are going to be easier on the system as opposed to a solid. So a lot of times, if you're not hungry, or if you're having a hard time getting in quite a bit of nutrition, it's easier to get in a liquid and you'll get more calories in than nibbling and forcing through a solid item. Also, we look at the types of fiber that we're taking in, wanting to have more soluble fiber as opposed to the insoluble fiber. And I like just to use an example of an apple with these types of fibers. The skin on the apple is going to be the insoluble fiber, that more roughage pushing fiber that can contribute to more bloating or gas for some people, where the inside of the apple is the soluble fiber that's a bit more moist, soft, easier on the digestive system as a whole. Also, take in consideration fat. Doesn't have to be necessarily a fat-free diet, but should take fat into consideration, avoiding any greasy or fried items. These can often increase nausea or diarrhea and just overall discomfort. So for our functional tumors, they're going to have, of course, just discomfort, the tumor burden itself in terms of location and causing bloating or discomfort. But also, these tumors are secreting hormones and other amines that can cause diarrhea, cause flushing, as Katie just mentioned, and also affecting a patient's metabolism. So our patients that are having carcinoid syndrome, as Katie mentioned, often are having flushing, diarrhea. This is caused by increased secretion of serotonin and other hormones from the tumor itself. And so some of the things that we can do just to counteract that in terms of nutrition, making sure they're getting in nice amounts, are again, increasing the frequency of meals, but keeping the portions very small. And then also trying to avoid foods or items that may trigger these symptoms. So that is going to be smaller portions, because larger portions will take longer to digest. You need, of course, more blood flow for a larger portion or a larger meal. So smaller meals, avoiding foods that are spicy, even caffeinated items can trigger symptoms. Alcohol for many patients can as well. And for certain patients, they may be sensitive to amines. So these are going to be our histamine, ityramine, and progesterone. And so if need be, we'd also want to limit these items. Some of these patients also will be low in niacin, and so that should be checked and repleted as necessary as well. And also treating our steatorrhea, that can be, of course, for different reasons, but if you're on an SSA, may be common. So making sure that we are giving them the pancreatic enzyme replacement therapy as needed, and helping them with dosage to get the maximum amount of benefit from those. Whoop. Sorry, looks like I went back too fast. I need to go back on the slide. I might need some assistance if possible to going back to the previous slide. Thank you. So often, like I said, patients will say, what should I be eating? And because of some of the issues I just expressed earlier, there is not one diet in particular that I feel like works for everybody, or everyone does need to follow. We do have to take the tumor location into consideration, if it's a functional or non-functional tumor. And again, if you are being sensitive to amines. So when it comes to amines or foods that are high, it's usually going to be foods that are fermented foods, pickled, aged, such as like aged cheeses. It's like you saw the aged cheese on the previous slide. These are the items that, if you are sensitive to amines, to keep in mind. Even something like a banana, of course, it's not necessarily fermented, but the more ripe the banana is, the higher an amount of amines that it actually is. So again, I tell people it's good to be aware and listen to your body. And it can be really difficult when you're not on treatment and you're not tolerating a lot of things. So we do need to take treatment into consideration as well when we're saying, is this something that I tolerated or did not tolerate? Where you are in the treatment, have you started? Is the disease stable? Are we having progression? All of these things can actually affect what may appear or actually be a true food intolerance. So with our gastrinomas, because of the increased amount of gastrin itself, it does, of course, cause some diarrhea, can cause some steatorrhea, abdominal pain, and again, just reduced appetite, resulting in weight loss because eating is uncomfortable or results in diarrhea that occurs very quickly after eating. So this is another case where we use small frequent meals and definitely using some PERT therapy to assist with the steatorrhea if present. Because of the gastrin, patients are at risk for having a B12 deficiency. So I do encourage checking for that and then repleting as needed. And then also having a good amount of electrolyte fluids because, again, because of the diarrhea and the risk for becoming dehydrated. So with our insulinomas, of course, the most common feature is going to be the hypoglycemia that's affecting the nutrition status. So this is where, again, we want to have the small frequent meals, but more specifically, foods that are high, that have a low glycemic index. And so having that every 2 to 3 hours is going to help to keep the patient's blood sugar stable for longer periods. So as you can see here, our toast, but specifically our whole wheat toast with our peanut butter, is going to be a low glycemic index. And the peanut butter is going to, again, help to keep the blood sugar stable for a bit longer as opposed to spiking and coming down pretty quickly. And so for those patients who are on therapy and are still having lower blood sugars overnight, they can do like a starch slurry. And there are quite a bit of recipes out there for that can make it a little tastier than it sounds. There are also several products on the market that are low glycemic index type products that come in the shape of bars or protein shakes that can help to keep blood sugars more stable for an extended period of time. For our glucogenomas, again, a whole kind of slew of different symptoms they may experience. Unfortunately, blood sugars being affected, a very painful rash, necrolytic migratory erythema, weight loss. These patients are also at increased risk for not having enough niacin or zinc, and so that should also be checked and repleted as needed. These patients, unfortunately, also are at increased risk for being anemic, as I mentioned. So checking that and repleting with iron is necessary. And also just some PERT therapy if needed. So for our VIPomas, a lot of other factors. I feel like the main thing we see with these patients are just the increased loss of fluids with diarrhea and dehydration, often landing them to the hospital. So one of the things that we want to focus on is getting in a good amount of electrolytes as opposed to just sipping on water throughout the day, being more intentional with what we're putting back in because of the loss of potassium and sodium that they're losing from their stools. And avoiding any caffeinated beverages or energy drinks that are going to act as a diuretic. They're going to further the problem. For our somatosinomas, again, it's going to affect our blood sugars. Unfortunately, steatorrhea is, as you can see, a very common problem with a lot of these functional tumors. With our somatosinomas as well, there are issues with absorbing calcium in our small bowel, so this can increase risk for gallstones. With these patients, it does not have to be necessarily a fat-free diet, but fat should be taken into consideration. Excessive amounts of fats or certain amounts, depending on their sensitivity, can make diarrhea worse. So again, small frequent meals, PERT therapy, some of the common things we're seeing with these functional tumors. So overall, I would say tips for just managing the food intolerances are: one, keep a log. Also include the stress level, because when you're stressed, I think, whether you have a neuroendocrine or not, that can affect your digestion and ability to tolerate certain things. Also, retry different items at different times throughout just the journey of being treated. Again, you may not tolerate something in the very beginning, but after being on treatment for 2 or 3 months, you may be able to tolerate it a bit better. If there is progression, may not be able to tolerate it and have to put it on the list of things that we don't tolerate or we don't do unless it's a special occasion. We kind of know what's coming. The other thing is I strongly encourage people to not just eliminate a whole food group unless there truly is an intolerance, because you can, when you do that, reduce your total intake of calories and then have unintentional weight loss that causes loss of lean body mass, and then we run into other issues as well. As I mentioned earlier, keeping treatment in mind, where you are with treatment, and when you're having the intolerances, you may be more sensitive at different times during the treatment, week of, week after, and so you may have to adjust diet during those times as well. So I'm not going to go into great detail with the slide. This is more for a visual effect. I have here, as you see, our esophagus and our large intestine, our whole kind of just system, GI system in terms of digestion. What I would like for you to see and take note of here is how many nutrients and vitamins and where the involvement is. And so when we have something like colon resection, um, you're at a less or a lower risk for having deficiencies. Where if you're having a small bowel resection, as you can see, especially with the ileocecal valve being removed, you're at a higher risk for, having other vitamins and nutrients we need to monitor. And then when we have something as complex as a Whipple surgery, as you see here on our other slide, there's just a lot more that you need to take in consideration in terms of nutrients and vitamins that can be affected because of the new anatomy itself. So after surgery, typically for 4 to 6 weeks, patients will have to adjust their fiber, their fat, and their sugar content. Now, I will say for our small bowel resective surgeries, they usually are able to progress their diet much more quickly, but they do still have to keep in mind foods that can be triggers that are higher in fat, higher in sugar. All of our patients for the Whipples and small bowel resections do have a higher protein need for at least 6 to 8 weeks out of surgery, just because we need to promote healing of the body after the major surgery. So lean protein sources there. And again, smaller, more frequent meals, just because it's going to be easier to tolerate, and they're working their way back up, hopefully, to the 3 meals before surgery that they were able to tolerate. So often we're going to see changes in bowel movements, especially after a surgical resection. So this will be, of course, increased transit time. I do strongly encourage my patients to give themselves adequate time after surgery to eat their meals, because in the past it may have been where you could eat a meal in 10-15 minutes and run on to the next activity. After surgery, you need to give yourself adequate time to eat your food slowly so that you can, one, tell when you're full, help to reduce bloating and gas and other discomfort, because this can increase your risk for having diarrhea, steatorrhea, or dumping syndrome. So it is really important to listen to your body. Don't advance the diet too quickly. And foods that you don't tolerate, try to avoid and limit them. So again, as I mentioned on the first slide, when we're looking at our vitamins and nutrients, minerals are going to be absorbed and where they're going to be absorbed. For our small bowel, you can see there are going to be several, but not nearly as much as if you're having a Whipple procedure. And so these are the labs. I'm not going to go over all of them individually, but I do encourage patients to have these checked either by their primary care physician, or if they're still seeing their surgeon, at least once a year, because they are at risk for being deficient in these vitamins and nutrients. For the DEXA scan, it's going to be every 2 years, because for our Whipple patients, they are going to be at increased risk for osteoporosis. And so we just want to make sure that we're taking care of them and getting things done before we get to that point. So lastly, I would just encourage everybody to help to empower our patients. I feel like as clinicians, we're telling them often this is a unique disease and how it presents itself, and even for the treatments. But I do feel like explaining to them some of the unique features and how things are affected, where their tumor location is because of their treatment, or even because their surgical resection, of how and why their body is responding sometimes in the way that it is. Often our patients will have multiple things. They may have carcinoid syndrome, they've had a bowel resection, they're on SSA. And so there are multiple factors that are at play, but helping them to kind of see some of the things that are coming through. Are their bowels burning? Are they oily or fatty? Helps them to take a little bit more control in terms of what medications they may need to take or to talk to you about in terms of their bowels. And also, like as I mentioned, just encouraging them to keep a food diary to help them keep track of it, so that when they do come to clinic to speak with us, they can express in real time kind of what happened and transpired, so that we can help them as well. Thank you.
That was fantastic. It's kind of intimidating to see that potential nutritional deficiency list, but thank you. So we will transition to our last speaker today. We get to, I'll hand it over to Tiffany to talk about the pathology classification.
Thanks, Rachel, and Good evening, everyone. Thank you to the speakers too for being flexible. I was supposed to start off the talk tonight and kind of give you the overview of neuroendocrine tumors and how we classify these tumors, which I will go into now. But so we'll pretend that we're rewinding for you guys to kind of give you the framework of neuroendocrine tumors. But thank you for the speakers for being so flexible and great talk. So I have no disclosures. So for neuroendocrine tumors, a little bit of background. They arise from the diffuse neuroendocrine system. Typically, we're looking at what we would call indolent or low-grade, slowly growing tumors. They typically will stain diffusely and strongly positive for synaptophysin and chromogranin. And they do have a propensity to secrete peptide hormones, amines, and various vasoactive substances. So a few of the main categories that we look at for neuroendocrine tumors are carcinoid tumors. The origin of these tumors is the endochromaffin cells of the digestive tract in the lungs. If they do secrete hormones, amines, so they can secrete serotonin, catecholamines, histamine. For pancreatic neuroendocrine tumors, the origin of these tumors is the islet cells of the pancreas, whereas pancreatic adenocarcinoma, we're talking more of the ductal cells. So pancreatic neuroendocrine tumors, majority are non-functional, as are carcinoid tumors. But those that are functional may secrete, as Stephanie was telling us, various hormones that lead to syndromes. So we can see excessive excretion of gastrin, insulin, glucagon, vasoactive intestinal peptide hormone, somatostatin, and PTH. With medullary thyroid, these tumors originate with the parafollicular C cells, and the hormone that they are responsible for is calcitonin. And then with our pheochromocytomas, the origin is the adrenal medulla, and the hormones they may secrete are epinephrine and norepinephrine. So one of the ways that we still classify these tumors when patients are coming to us for looking for their diagnosis and their treatment is we try to identify the primary site of tumor. We don't always find it. They're just like other solid tumors. There is a small percentage of neuroendocrine tumors that have an unknown primary, approximately 15%. But in the vast majority, we will identify a primary site. Those tumors that originate in the bronchial tree, the stomach, or the duodenum, we can also call them foregut tumors. Midgut tumors, which are your classic carcinoid tumors, originate in the small intestine, either the appendix or the proximal colon. Most of the small bowel tumors will originate in the terminal ileum. And then those that arise in the hindgut are tumors that arise in the distal colon or the rectum. So after identifying the primary site, then we also want to look at the differentiation as well as the grading. So the difference between the two is that the differentiation refers to the resemblance of the tumor histology to its normal counterparts. And the grading describes the proliferative activity of the tumor as measured either by the mitotic rate or the Ki-67 rate. So within NET differentiation, we have well-differentiated neuroendocrine tumors, which are also stand for NETs. And we have poorly differentiated neuroendocrine carcinomas, or NECs. Our NETs, or our well-differentiated neuroendocrine tumors, have the characteristic organoid arrangements of tumor cells with solid nesting, trabecular, gyriform, or sometimes glandular patterns. These cells are highly uniform, and they have round to oval nuclei, coarsely stippled chromatin, and finely granular cytoplasm. Poorly differentiated neuroendocrine carcinomas mean they look less like healthy cells. They are divided into large cell and small cell type. And this refers to what the cells look like under the microscope, which we'll talk about in a few slides. And all of these poorly differentiated neuroendocrine carcinomas are treated the same. Some things to know about this subgroup of neuroendocrine tumors. Poorly differentiated tumors have a rapidly progressive clinical course. They do, unfortunately, have fewer treatment options. Really, the only established is first-line therapy with either carboplatin or cisplatin plus etoposide. Second-line therapy is not well established and is really driven by the experience of the provider, the patient's tumor profiling, as well as the primary site of disease. So other treatments that we commonly use for these folks in second line and beyond would be some of your more traditional GI chemotherapy cytotoxic regimens like FOLFOX, FOLFIRI, CAPTIM, and then some immunotherapy, as well as we always encourage clinical trials. So here, and I have to preface that I'm by no means a pathology PA. So my background is all medical oncology, but I had to bring some slides to you guys from up to date so that you could see the difference between well-differentiated neuroendocrine tumors, which is depicted in slide A. And this shows an organoid pattern in difficult to find mitotic activity. And the proliferation rate, as measured by the Ki-67 labeling index, is very low, less than 1% in this case. And then by contrast, the poorly differentiated neuroendocrine carcinomas show frank features of carcinoma with numerous mitotic figures and numerous necrosis with staining. And the Ki-67 index is very high, greater than 80% in this case, which is depicted in D. So the difference then between small cell and large cell neuroendocrine carcinomas, the carcinomas themselves have a more sheet-like and diffuse architecture, irregular nuclei, and less cytoplasmic granularity. The tumor cells grow in sheets, forming nest-like structures, often with large confluent areas of necrosis. We do often see perineural and vascular invasion. Small cell carcinomas are composed to small to medium size, round to oval cells with scant cytoplasm. And large cell carcinomas are composed of large cells with vesicular nuclei showing prominent nuclei and abundant eosinophilic cytoplasm. So then there's also another subset, very rare, but we do see it and you should be aware of it. And this is that some of our gastroenteropancreatic neuroendocrine carcinomas may contain non-neuroendocrine components. What that means is on the pathology, it may be interpreted as having part adenocarcinoma or part signet cell carcinoma, and then more rarely squamous cell cancer. If the neoplasm consists of a neuroendocrine component and a gland-forming component, both exceeding 30%, then the new 2019 WHO classification defines it as a mixed neuroendocrine, non-neuroendocrine neoplasm, or menin. So after we have developed or differentiated the differentiation of the tumors, whether it's we're looking at a well-differentiated or a poorly differentiated NET or NEC, next we depend on our pathologist to tell us the tumor grade. And as I said, that's really based on the mitotic rate or the Ki-67 rate. So grade 1s have a mitotic count of less than 2 and a Ki-67 of less than 3%. Grade 2 tumors have a mitotic count of 2 to 20 with a Ki-67 of 3 to 20%. And grade 3 tumors have a mitotic rate of higher than 20 and a Ki-67 of more than 20%. So then how do we differentiate now between a well-differentiated G3 and a neuroendocrine carcinoma? So G3 NETs more closely resemble non-neoplastic neuroendocrine cells with the characteristic organoid arrangements of tumor cells with solid nesting. So they appear more like healthy cells on the well-differentiated side. The cells are relatively uniform. They tend to still have the round to oval nuclei, coarsely stippled chromatin, and finely granular cytoplasm, just like the well-differentiated tumors. And so one way that you can differentiate, recent data suggests, is having this pathologist seeing this organoid growth pattern in conjunction with capillary network in direct contact with the tumor cells in the absence of desmoplastic stroma. This can help differentiate the two. And then also on immunohistochemical staining, it might be helpful for differentiating NECs from NETs, a G3 particularly, as the example of pancreatic NETs show a loss of DAX and ATRX in roughly 1/2 of cases, similar to our pancreatic NETs grade 1 and grade 2, whereas loss of RB1 expression or abnormality of P53 supports a diagnosis of neuroendocrine carcinoma. So again, with all of this, we're relying heavily on our pathologist. Once we get the specimen, either from biopsy or the surgical specimen, to give us this information. And this helps us kind of formulate our treatment plan for the patient, and we can give them the accurate diagnosis of whether they have a well-differentiated G1 tumor of the small bowel versus a well-differentiated G3 pancreatic NET, or do they have a NEC, in which we go a different avenue of treating. So this kind of just highlights everything that I just discussed in terms of the GI classifications. So we talked about NETs, G1 through G3, and then small cell type as well as large cell type NECs, and then menins, and how we differentiate those between the mitotic rate and the Ki-67. So changing courses just a little bit to talk about lung NETs. So in contrast to our GI NETs, the terms, we still kind of use typical and atypical versus low and intermediate grade tumors arising in the lung. So the mitotic rate, rather than the Ki-67, and the presence of necrosis are the primary determinants of the grade for lung NETs. And the terms well-differentiated NET, so a low grade would be a typical, and a well-differentiated NET intermediate grade would be an atypical carcinoid, are preferred. So this again, a pathology side showing a typical low-grade lung NET composed of cytologically bland cells containing regular round to oval nuclei with the finely dispersed chromatin and inconspicuous small nuclei. The cells are usually polygonal in shape and are arranged in distinct organoid, trabecular, or insular growth patterns with a delicate vascular stroma. 50% of lung NETs do stain positive for TTF1, although the staining is often weak and focal. Whereas this is the pathology side of an atypical pulmonary carcinoid tumor. And these typically include the presence of either necrosis or having a mitotic rate of 2 to 10 per 10 high power field. You tend to see cytologic atypia, which is characteristic but is insufficient for the diagnosis in the absence of other features. And these intermediate grade tumors are tend to be more associated with hilar and mediastinal nodal metastasis versus our typical carcinoid tumors, and they have a higher recurrence rate. If they do stain for neuropeptides, examples are CD56, chromogranin, synaptophysin. It can be helpful for the pathologist to help make the diagnosis, but it's not required. So again, and then within the subtype of lung NETs too, we also have the large cell neuroendocrine carcinomas as well as the small cell carcinomas. So this is basically the overview again of what I discussed. Just want to touch on the very first component, which is diffuse idiopathic neuroendocrine cell hyperplasia, or DIPNEC. So in these patients, they tend to have multifocal, very tiny sub-centimeter tumorlets, with or without having a diagnostic carcinoid tumor, often very slow growing. We can monitor them for years. You do monitor them to make sure that none of the tumorlets develop into carcinoid tumors. But just know that also exists. And I think that is, the end of my slides. So I'll turn it back over to Rachel. Thank you guys so much for your attention tonight.
Thank you, Tiffany. That was fantastic. I feel like I learn a little more about pathology every time I get exposed to it. So we will now open up our question and answer portion of the night. As a reminder, if you have a question, please feel free to type it into the Q&A box. And while we're waiting for questions to come in, I've got a few to get us started. So the first one's for Katie. Can you talk about some of the recent changes that have come out for those patients with chronic kidney disease or on dialysis in terms of dosing of your lutetium dotatate?
Yes. So There was a recent journal article that was published in Journal of Neuroendocrinology that discussed that it actually recommends patients with a GFR that's less than 30 should have a 75 to 85% reduction of the lutetium dose that they're getting. In addition to that, the patients also need to be informed of the high likelihood of further reduction of their kidney function after they receive this treatment. So something to keep in mind when you're managing these patients, if you're either seeing them between cycles or after they finish PRRT, to make sure that we're really closely monitoring the creatinine clearance. Even if they're already seeing a nephrologist, making sure that the nephrologist is on board and knows that these patients are going to need close follow-up.
Okay. My next question is for Stephanie, and I appreciate the very strategic approach of how you broke down the different ways we should think about nutrition for our patients. It seems like so many of the times you've got the patient who's got every category, right? The altered surgical anatomy, the functional tumor, and side effects from every treatment their medical oncology team is throwing at them. How do you help a patient balance when those things have competing recommendations from a nutrition standpoint?
That's a good question. I try to explain how those various factors are affecting them. Like I said, if you're having carcinoid syndrome or if you're on an SSA, these are things to take into account. So low fat is usually the way to go, and also smaller portions. And from there on, it kind of becomes how much more of a challenge do I want or can I handle? But good sources of protein, lean, baked, or grilled or roasted, are going to be preferred. But that's usually where I'll kind of have patients start. Anything beyond that realm, again, becomes, can I tolerate, lasagna? Do I want to take that chance? Can we have a lasagna modified where someone can make it for you homemade and reduce the fat and maybe use something you can tolerate better? But then also helping to assist them with the medications they need and the dosage they need to enjoy those meals in the places with family or friends as well.
Great. Next question's for Tiffany. Um, so you touched a little bit on some of the challenges with classification and differences between the GI classification scheme and lung. In terms of kind of those grade 3 tumors, I think we've seen kind of a merging of the well-diff grade 3 patients really being recognized. And, I think there's a thought that Ki-67 is probably going to be lower than the poorly differentiated counterparts. But when you have a patient who falls into a grade 3 net range and that Ki-67 still high, 80% or higher, does that sway how you think about their treatment approach in terms of, do you model it more after how you might treat a neck patient, or are you still letting the differentiation guide first?
Yeah, that's a great question, Rachel. So, like thinking back right now at our institution, I still think that we rely on the differentiation first and foremost. And so, if the pathologist is reading it as a neuroendocrine carcinoma, we would still go with our first line, carb etope. But then depending again upon the primary site of disease and what the Ki-67, then, think about for second line at that point, definitely getting the patient's genomics completed at the first line. So you can target any actionable mutations and thinking about immunotherapy and so forth. So I think that is still kind of how we're looking at things and depending on differentiation first.
All right, circling back a little bit to the PRRT questions, I'm going back to Katie. With some of these clinical trials, looking at different approaches with PRRT, is there thought that, that's going to change our management in terms of some of those supportive cares? Or I know it's hard to say, but do you think what we know from Lutathera will apply as we move forward?
I think this side effect profile will probably be similar with some of the newer agents. I know like there's a clinical trial for an alpha emitter instead of a beta emitter. But the symptoms that we notice, like the diarrhea, the increase in carcinoid symptoms, are really coming from the somatostatin itself. So either like inflammation, because we're causing inflammation to the tumor, and can cause things like small bowel obstructions or abdominal fullness and pain. Or the diarrhea, like when you're destroying the tumor, it's releasing somatostatin. So you get this increase of somatostatin, which is really driving a lot of the symptoms that patients are experiencing. So I don't think that's going to change based on the alpha or beta emitter that we're using. As long as we're targeting a somatostatin receptor, we're probably going to see similar symptoms.
Thanks for sharing the thoughts on that. Another question regarding from a pre-med standpoint, are you guys using antiemetics as part of the pre-meds? I know there's been some debate about what to use, how much to use, is it really needed as some of the amino acid formulations have changed?
Yeah, that's a really good question. So yeah, we recently had an issue like with our amino acids that we usually get from a custom pharmacy weren't delivered. So we had to look into commercial ones. And the problem with commercial ones is they use a lot more amino acids. These are commercial ones for like TPNs. And there's a much higher emetic risk related to those, especially with like the rates that we have to infuse them for nephroprotection. So reducing, like having these custom ones where you're really just getting the 2 amino acids that you really need to protect the kidneys, you get a little less nausea and vomiting from that, but you still get some. And in addition, the PRRT itself causes nausea and vomiting. So it's very important that you have pre-treatment antiemetics on board. Our standard is to do Zofran 8 milligrams. I do have some patients that did, like this last patient, case number 2, this 76-year-old female, she didn't respond to the Zofran. So for her next time, I'm probably going to keep the Zofran on board because it might have helped a bit, but I'm also going to add compazine to that. For other patients that, if they haven't responded to the compazine or the Zofran, we can look into other things. That might be a patient where I might go to MedOnc and consider like, okay, well, everything else isn't working. I want to keep them out of the ER while they're in radiation isolation. What do you think of using a glucocorticoid for them? But yeah, usually patients do very well with the Zofran and then compazine. And in addition to the pretreatment, again, making sure that they have a script that they've either picked up prior or their loved one can pick up for them to make sure that they have something to cover them for the days following as well.
Okay, I think we have time for one last question. So I'm going to go back to Stephanie. You mentioned steatorrhea as a very common in terms of pancreatic enzyme replacement and sometimes challenges with cost of prescription enzymes. Do you have any tips for helping patients navigate some of the supplements and over-the-counter options?
You're right. This comes up really often just because of how often we do see steatorrhea in our patients. A lot of the our prescription providers do offer patient assistance, which I think is a real big benefit. And I don't think enough people or patients look into them. So that's the first place I'd start. Over the counter can get a little tricky because they're not a one-for-one trade-off. And so they're not FDA regulated. There's also the dosing that gets a little tricky. There are a few I feel like they can be helpful. But I would say you talk to the dietitian or your dietitian so they can help to guide you because it gets really tricky. And there's so many over-the-counter enzymes and some just are not worth it for the amount of steatorrhea that our patients are having. I don't like for our patients to get full of, say, 10 pills and then try to eat their meals. So I think their teams could kind of help them, if they can't afford the prescription dose ones, kind of guide them to some potential over-the-counter options.
Thanks. That's great advice. As I look at our Q&A session, just wanted to thank our attendee who commented on correlating that pathology with the clinical behavior, and always remember the potential to rebiopsy. That's a great advice when it comes to these patient and sometimes the challenges we face. And then I'd echo our second comment to say amazing presentations, really outstanding. All right. Any additional questions? And so as we wrap up tonight, a few last housekeeping items. NANETS recognizes the medical education and professional networking needs of advanced practice providers and allied health professionals in the NET medical community. As such, NANETS has established a travel grant for APPs and AHPs to attend the annual NET Medical Symposium. The travel grant award for selected individuals will include complimentary registration and up to $1,000 reimbursement towards airfare and accommodations. Travel grant opportunities are open to non-physician healthcare professionals, including dietitians, genetic counselors, nutritionists, pharmacists, physician assistants, registered nurses, nurse practitioners, and clinical research coordinators. For full details, please visit the NANETS website, as well as the link to the application that is being placed in the chat. Deadline to submit is June 12th. Also, please join us for our next APP-AHP Special Interest Group meeting being held June 11th at 7 p.m. Eastern Time. If you do not have the calendar invite, please reach out to the NANETS staff@nanets.net. And lastly, stay tuned for details on registration for our 2024 NANETS Multidisciplinary NET Medical Symposium held November 21st through the 23rd at the Chicago Marriott Downtown Magnificent Mile. We hope to see more of you at these future opportunities.
Thanks, Rachel, and fellow speakers. Appreciate it. Everybody have a wonderful night.
Okay, thank you. You too.